also?
Yes, I can see you. Yes.
Right.
Perfect. So let's start. Good evening, everyone. I'm Dr. Asita. I'm the chair of College of General Practitioners Elderly Care Committee. And I welcome today our resource person, Dr. Kelum Pelpola. He's a general physician as well as a well-recognized geriatrician. Let me introduce him to you. He has worked in UK in Norfolk and Norwich University Hospital as a clinical director, and he has worked there since 2016 to 2021. And I'm proud to present him today on our very first webinar. Sir, the screen is yours. I'll share the screen. Can you see, sir?
No, yeah, I can see a green screen, but not the presentation.
Yeah, well, I'll share.
Right.
Wait, I'll put it to the
Full screen.
full screen.
So, thank you for the kind introduction, Asita, and I'll start on the presentation today. So, we are talking today about compassionate care during the final stages of illness. So, this will talk about what kind of care we can give and for what kind of diseases and how to plan it in general. So can we have the next slide, please, Asita? Right. So now I will talk you through some aspects to think about when you come towards the last stages of life. So now here I am talking roughly about the last year of life for someone. So then here we would have to think of how do we feed the person? Because sometimes you may know if a person who has end stage dementia, they may not be able to swallow properly. So how do we feed them? Are we giving them food through mouth? Are we giving an NG tube? Are we having a peg? And if we are giving through the mouth, are we accepting that there's an aspiration risk? And have we discussed it with family? Those kind of things are very important. How about the fluids? How do we give the fluids? Again, oral, intravenous, subcutaneous. All those options are there, but we may have to tailor it to the person who's having it. What about the blood tests? Are we doing blood tests or are we not doing blood tests? Antibiotics. Have we decided to give antibiotics or whether we have come to an agreement with the family and the patient or either of them that they would not have antibiotics and we will have to let them go peacefully? What about hospital admissions? When someone is really unwell, would we want them to admit to hospital every time that they fall sick? Or would we try to manage them at home? And if we are managing at home, who is going to help us with that? Is there a community nurse who can help us? Is there a home service which can help us? All those things matter. And how do we control the symptoms? So when you come towards end of life, pain, agitation, secretions, vomiting, and shortness of breath are very well recognized symptoms that can occur. So we need a plan up our sleeve as to what we should use for that kind of thing. And then about cardiopulmonary resuscitation. If by any chance the patient goes to a cardiac arrest, what are we going to do? Are we going to give resuscitation or not? And here is where we come to advanced care planning. Asita, can we get the screen again? I'll just be talking a little bit about advanced care planning. So this is a concept that we find a lot in the developed countries now. So what is this concept? So there are definitions regarding advanced care planning, and I would like to give it to you. The next slide is on that. I would like if Asita could come online. Asita had logged out by error, so he's not trying to come into the presentation now. So I think so. We were talking about advanced care planning. So let's see what advanced care planning is. So when you talk about advanced care planning, uh, it's good to use a definition. So can we get to the definition, Asita? Can we just see? Can we go slightly? Yes. So that's the definition. Advanced care planning, right? Have a look at it, read it, and see what you understand about it. So when you talk about advanced care planning, the definition is advanced care planning is a process that supports adults at any stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, preferences during serious and chronic illness. So this is the international guidance and the definition regarding advanced care planning. But what it means in simple language is that advanced care planning can be given for a certain kind of illness where they get unwell towards the end of life. And this is a plan that you make along with the patient according to their values, what they want in life, and preferences. And this is done at a time when they actually are able to make decisions. Right. The next one is a multiple choice question. When should you ideally use advanced care planning? So can we get to that? I think that slide 4. It's a little bit higher. Asita, are you able to get into that? Go to slide 4, please. Yes, yes. Go up a bit more. I think we need to get to the top of it, Asita. Right, yeah, that's the one. That's the one. When should you ideally use advanced care planning? Just go down a little bit more. So the multiple choice question has a few answers. Yes, that's the one. The last slide there. So for 1, for a patient with advanced dementia, 2, severe heart failure, 3, severe COPD, 4, stomach cancer with metastasis to multiple organs, 5, all of the above. So what's the answer? So the participants can look at this and they can type the answers. I'll give you 30 seconds for that. When should you ideally use advanced care planning? What's the correct answer? Yeah, the overwhelming answer seems to be correct. Number 5, all of the above. So as that you can see, it is not for any particular condition. It could be any condition. So as a GP, it's very important to realize that if you plan in advance, then you will be able to actually make most of your patients' lives better. But it's good to plan early. And for that, you have to identify the condition deteriorating early. So advanced dementia, heart failure, COPD, cancers, all of these conditions, and very much benefit from using advanced care planning. So when you talk about advanced care planning, there are 5 major things that you have to plan about and do. The first is to think. So you have to think about the future as to what is important to you, what you want, and what you want to happen in your life. So that's why you say you need to get the patient involved in this discussion as soon as possible. When the patient is able to make his decisions, then you talk. You first think, then talk. Don't worry if you don't see the presentation. We will send the presentation to all of you at the end so you can have it if you want. So then you talk to friends and family. So you talk to patient, the family, their friends, and then you make these decisions. After you make the decisions, you record it. Yeah, that's the slide. The third one is record. You write it down in a paper, which would be a binding document for future care planning. Then you discuss your plans with the doctor. This includes things like resuscitation and all of this. And then you share this information with the others in a formal way. So the next slide, the one in the yellow board with the yellow border, shows an advanced care planning form, which you can see in places like UK. So you may see that countries like this has an advanced system where they have a document like this. Normally in places that I work, what happens is they fill in this form, and this patient or the guardian and the doctor who makes the decisions, they sign both the form, and then it becomes a binding document for future care. Obviously, if there are changes in the future, obviously you can talk and discuss and then come to a conclusion again and change it even if required. So the next slide will go to practical issues when doing advanced care planning, because it's good to say to have a plan, but there are a lot of practical issues when it comes to this. The first thing is the reluctance of medical practitioners and patients to discuss advanced care planning. So a lot of doctors don't like discussing this because they don't feel prepared for it themselves. If they have not been trained to do it, they feel afraid to do it. So they also are worried it will take a lot of time. And in a busy clinic, they may not have the time to do it. So because of that, they may be reluctant to do it with the patients. The patients may not be wanting to discuss about it because then they may think, oh, the doctor is discussing this with me because I'm going to die. So I don't want to discuss about it. So that may be a practical issue. Then patient demands. Some patients may demand from you and say, whatever happens, I want to go and get everything done. I would want CPR. Even if it doesn't work, I want CPR. What you have to know in these situations, especially when I have worked abroad, the law there is that a patient cannot ask for unwarranted treatments. Say, for example, if a panel decides that they will not benefit from something like CPR, when you say a panel, what happens there is normally one of the consultants looking after the patient will discuss it with them. After that, if the patient doesn't agree, they will put it to another independent doctor. That doctor will also look at everything and see whether they feel resuscitation is not appropriate. Both of them decide that that's the case, they will go ahead and say, okay, we are not doing resuscitation. And if the patient still says, I demand resuscitation, that will not be granted because it is an unreasonable demand and you cannot do unreasonable demands. Then the patient's mental capacity. Sometimes you may find when the patient already comes to you, they may not know what they're talking about. They may be very confused. They may be advanced in their dementia. Then they would not be able to make any decisions. So you may have to talk to the family. And then the last one is next of kin, who to contact. So if you actually think of who to contact, most of the time, it would be the patient if they have capacity. But if the patient doesn't have capacity, you have to have some person to contact. Sometimes the patient may not have an extra fee. Sometimes even they have an extra of kin. There may be about 3, 4 children, and they may have different ideas about the mother or father. And it becomes very complicated. Some people may say, the patient has had a good life, let them be comfortable. While the other one will say, no, I want to do everything for my mother or father. Then you are having a dilemma. Then what should you do? So these are practical issues that you can have. Can we go to the next slide, Asita? So the next one is cardiopulmonary resuscitation, CPR. So when you are talking about cardiopulmonary resuscitation, I have found that in Sri Lanka, we very rarely talk about cardiopulmonary resuscitation. But in my practice, I have started doing that, and I have found that people are receptive to it once you tell them all the details. Sometimes it may take a lot of time to discuss, but once you do it, it's a very rewarding experience for you, the family, and the patient. After all, as we always know, the patient should be at the center of the care, not anyone else. So, what aspects to consider prior to starting a discussion? So, one aspect is, how is the patient's current condition? Are they a patient who is bedbound all the time, who cannot communicate, or are they someone who has a sound mind and who can make decisions about their condition? Who should you discuss it with? Again, is it the patient? If they have capacity, the patient should be discussed. It should be discussed with the patient. The patient's family cannot say, "Oh, we don't want to discuss it with the patient." The patient has said that they want to discuss it with the patient themselves. Then you have to go ahead with the patient. But if the patient says, "I have capacity to decide, but I don't want to discuss it with you, but you can discuss it with my family, and I'm happy with that decision," then you can go ahead with the family's decision. What should you discuss? So when you're talking about CPR, what should you discuss? So when you're normally talking about this kind of thing, you should take it in steps. Sorry. You should tell them why we do it. We have to tell them, say, for example, it's a 15 to 20-year-old, generally a young person who has no comorbidities at all. The chance is that a person who drops dead in front of you, if they have no comorbidities, still a 20-year-old, the chances of them reviving is only about 15%. 85 times out of 100, they'll either still be dead, or even if they come out of it, they'll be like what you call a vegetable. So those kind of important facts should be told when you discuss these things. Otherwise, people will not be receptive. And then you can say, when you assess how this patient is, their current condition is, you can tell them that actually you feel that with the given comorbidities, whether it is worth or not worth doing resuscitation. You feel it's doing more harm to the patient than anything, then you make sure that they actually understand why resuscitation is not done. I think we need to go to the next slide. So actually, I had a nice question and answer session from here. So we'll go to the next one, please. Okay, there you go. So this is a small question and answer session I wanted to do with you all. So read this question, and there will be something at the end where you can send the answers to. Read the question, please. Now I'll give you 1 minute. Asita, can we go up a bit? Yeah, okay. We'll go to the end of that, the question. Yeah, okay, right. So now I'll give 15 seconds more and let's see what's the next best step of management. Right, can we go to the next slide, please? Right. So from 1 to 5, what's the best answer? So basically, while you look at the answers, I'll give a recap. This 88-year-old lady comes with the daughter next of kin. She's a known patient with dementia, but no other comorbidities. She has had dementia for the last 10 years. And now she's coming with recurrent problems, and we had all the clinical information there. So number 3 has come, 5 has come. Anyone else? 3, 5, 5, 3. 3 and 5 seem to be repeating a lot. 1 is there. Okay. So I'll give about 10 seconds more and I'll explain the answer. Right. So we had 1, 3, and 5. There was 1, 2. So I think we have, given enough time for everyone to answer. The answer is number 3. The reason I say the number 3 is the answer is because this patient has had no advanced care plan before. So when they come in an acute situation, it's not ideal for you to start an advanced care plan right at that moment. No, that is not how it is done. An advanced care plan has to be started well in advance, not at an emergency room at the very last moment. So as soon as someone comes, the obvious correct way to start is start antibiotics, oxygen, and intravenous fluids until we get somewhere else. Okay, the next slide, please, and that's another question there. Okay, right. Okay, let's keep it there. Thank you. So I'll give you about 20 seconds more to tell the answer. Right. I think a lot of answers are coming in. The overwhelming majority, I would probably say 90% of them are saying it's number 4, and actually it is correct. So there was a few twos and fives I felt, but four was the overwhelming majority, and you're correct. So despite the initial management, after 1 hour, her condition remains the same. So you continue treatment and discuss further plans with the next of kin as soon as possible. Before, because I think now you get the idea from the history that this person probably should not be escalated to intensive care or not should be resuscitated. But before doing that, while continued treatment, you try to see whether you can get hold of the next of kin and try to communicate with them. So can we go to the next slide, please? Thank you. Right. Okay. Now this is the next question. Let's read this. Okay. So can we go to the next question? So what's the next step of management? Okay, let's go to the answers. So from 1 to 5, I'll give you 1 minute. Tell me what the answer is. Right. So I think we've given enough time to look at this. So basically, there was overwhelming majority again said 4 was correct, and actually 4 is correct. There was a few 1 and 3s I saw. So why is 1 wrong? Keep her on oxygen and fluids, but stop antibiotics. The family actually have told us that the patient is not suitable for further escalation, and they have indirectly told us that by saying that they don't want to prolong the agony. So that's why 1 is wrong. 3, again calling the intensive care team to escalate, it's wrong because the most suitable thing to do is to discuss with the family and commence comfort care. Because now she has come to a stage where the GCS is 3. She has further deteriorated. And bringing her back out of it is likely to put her through further distress rather than anything good for her. Okay. So let's go to the next slide, please. Thank you. Right. Could we have prevented this scenario with advanced care planning? What is your answer? Right. So there were a lot of answers. I think there was one I saw, then there was three, then there were a few others also. B is the answer. Yes, probably. Why isn't one correct? Yes, definitely. Why do we think one is incorrect? That is because despite whatever you do, whatever advanced care plan you make, I have had seen instances even overseas where it, it is not adhered to. That's why it's wrong. Most of the time, if there's an advanced care plan, 90% of the time things go correctly. But say, for example, there's a GP who's uncomfortable doing what is there on the advanced care plan, then they may send a patient to hospital. Those kind of things still happen. So that's why we can't say yes, definitely, but yes, probably. That's the answer. Okay, can we go to the next slide, please? Right. Considering the above patient, ideally at what stage should we have approached advanced care planning? Okay, tell me your answer. I'll give you about 1.5 minutes. Right. I think we have given enough time for the answering session. So the correct answer is number 5. So I'll tell you why. Number 1, before she got dementia at her 50th birthday. That is too early. You can't tell anything like that without any reason at someone's 50th birthday. Number 2, when her dementia worsened over the last 2 years, then that would have been too late. When the dementia worsened, she wouldn't have been able to be part of the conversation. Earlier this year, when she came with the first chest infection, still it's too late because she still can't be part of it. Because ideally, we want her to be part of it. When she presented with her last chest infection, that is also too late. Number 5, when she had early or mild dementia. In early dementia, you may know people still have the ability to think about things. So that would be a good starting point. So this is a good message for you all because you may see patients with dementia. And obviously, you know, at some point, this is going to get worse. They may come to a point where they are unable to swallow, they are unable to breathe properly, they are unable to communicate properly, they are back in very early, they are just like little children. And at that time, it is all too late. But in early stages, if you are a GP and you see that patient regularly, and you know that patient, you may be able to have a bit of a chat about what they wanted in life. What are their thoughts? Have they made a decision? And now I have seen a bit of a trend in the patients that I see. especially some patients around Colombo, they have made their wishes and sometimes they have communicated it on paper via lawyers to the family. And sometimes they do give me a copy saying, I have some patients who say they would like things like antibiotics, oxygen fluids, but they would not want to be connected to any machines. They would not want dialysis, they would not want intubation, they would not want ventilation. So they have thought about these things. So when the opportunity is right, say for example, if you have a patient who has early heart failure, you know that this is going to get worse. Maybe once they have one or two hospital admissions, or if they have one or two bouts of shortness of breath where they have to be treated with intravenous things, etc., you may have to ask them, have you ever thought of what you wanted in life? And if this got worse, what would you have wanted to do? So that's a good starting point. And starting that may come to a conversation which helps the patient in the end. You may not get somewhere in the first few conversations. Sometimes you may ask this over about 10, 15 conversations over about 1 or 2 years. But still, that gives you some information about what the patient would have wanted. And that's very important in these decisions. Thank you. So I've come to the final slide of my uh, slides show. But if there's any questions, I would like to answer. I'm sorry about what happened with the slides, but you can obviously have it. So I'm happy for you to have it and have a go through. But this is just a little bit of a pointer as to what you can do as GPs when you're seeing patients, because I feel it's a very important thing which we can improve on a bit more. Thank you. Please, if there's any questions, let me know. I'll be happy to take any questions.
Dr. Pelpola, there are these, some of these doctors have these memory clinics. They say it's for these dementic patients. In your experience, how good is it? And as GPs, should we refer these patients with dementia? And at what point of dementia should they be referred to these so-called memory clinics?
So it's like this. So if you talk about a memory clinic, you should probably see what kind of things are done in the memory clinic. So generally, as a geriatrician, I also see a lot of patients who see. I also see a lot of patients who have dementia and early problems with memory. As a GP, if you start seeing a patient who has memory problems, especially short-term memory issues, it's appropriate to send them to either a geriatrician or a memory clinic or a psychiatrist who specializes in memory. That can be considered. So what I would go by is, as you know a patient for a long time, if they come to a clinic a lot, suddenly if you find that they are struggling to find words, or the patient or the family may say then patient ගොඩක් අමතක වෙනවා පොඩි පොඩි දේවල් අමතක වෙනවා, then you can try some short questions. Say for example, I would ask something like අද උදේට මොනවද කෑවේ, ඊයේ රැට මොනවද කෑවේ. If they are struggling with that kind of thing, that's a good point to say, okay, here they have memory problems, then that is a good time to refer them so that something can be done. Because sometimes what happens is we get patients. So I also see patients with memory problems. I have been sent people for the treatment, but then it's too late, because as you know, a lot of treatment for dementia is aimed at reducing the progression of it. But we cannot get them back to what they were about 4 or 5 years ago totally, but we can definitely reduce the progression of the dementia, the medication. Unfortunately, there isn't anything much we can do when it is very advanced, because most of the medication wouldn't work when it's advanced. So I would say early detection. As I said, ask for simple things, simple short-term memory-related things. If they are forgetting, if the family or they know it, then it's a good time to start. I hope I answered your question.
Thank you. Yes, you did. Thank you.
Any other questions?
I think there was a question typed. I don't know. Let me check.
So patient with dementia lives alone, who will be considered as next of kin?
So normally it's like this. If there is a patient who has dementia and they cannot make a decision for themselves, then picking a next of kin will be very hard. Say, for
Hmm.
example, although the patient lives alone, they may have a son or daughter or any other close family member who is not living with them. Sometimes they may be abroad. So, technically, if there's a wife or a husband, or if there's a partner, or if there is a son or a daughter or a adopted child, any one of them could be technically next of kin. But sometimes if there is no one at all, then we may run into problems. In places like UK where I worked, if someone had no next of kin whatsoever, there was a procedure where we could appoint an independent person to act in the best interest of the patient. So
Hmm.
they could be asked to act in the patient's best interest. An independent person, they were normally appointed by the state. So that kind of thing was there when we were working in the UK, but in Sri Lanka, there isn't anything as such as yet. So what something to consider though is that although the patient is living alone, they may have distant relatives who are or are not interested in the patient's welfare.
Thank you, sir.
So someone has asked, do we need legal provisions for advanced plan? So currently there is no legal provision per se. However, I think we can at least make decisions regarding resuscitation with the patient. Say, for example, I have patients who have said very clearly in their legal documentation, which they have made along with a lawyer. So I have had these documents given to me saying, Doctor, this is your copy. We have made a document with our lawyer, and they have sent copies to their children also. And they have said very clearly in that, I would not want resuscitation. I would not want connection to any machines. I would not want so this and this. But I am happy to have these things. So if there is a document like that, I think we can go by that. But at the same time, if you know about something, when they are making a document like that, it's always good to make sure that they also make the family aware. Say, for example, some of my patients have sent copies to their children, and it is also mentioned in the bill itself. So then that's a good thing because then the family is aware. Because if the patient has done this and the family is not aware, then again a huge problem.
Hmm.
Dr. Kelum, this is Dr.
Yes,
Sudatma. Thank you very
yes,
much for the very comprehensive lecture. I have a small comment and a small clarification to ask from you. So I'm
yes.
talking with my personal experience. So my mother was diagnosed with progressive supranuclear palsy, which is an incurable neurodegenerative condition back in 2014. Her condition
Okay.
rapidly deteriorated over a period of 8 years, and she unfortunately passed away in 2023. So afterwards, only during that 8 year period, it was quite difficult for the family. And after she passed away, only I got to know that there are some programs in certain countries like Australia where they care for the carers. Say, for example, the family members are asked to admit the patient maybe once in 3 months to a specialized unit where the patient is looked after for maybe about 1 week or 2 weeks, and where the family members are allowed to maybe take a trip. They are allowed to go on a vacation or something, and the carers are taken care of by the system. is there such a system happening in Sri Lanka as of now, or is there a potential in the future for Sri Lankans? Because I think in our setup, this caring for the carers is completely neglected. What is your view on this?
Yes, I totally agree on this. I always in the Sri Lankan context. So, if you are looking at my practice, unfortunately, I am only working in the private sector because actually I did my all postgraduate work in the UK. So, when I came to Sri Lanka, pediatric medicine was not a specialty even. So, I only practice in the private sector. So, in the private sector, for the patients who I see, I always encourage them to do this. So sometimes, if you look in the government sector, unfortunately, there is no provision for this because I think they are very well inundated with a lot of other work. They are not giving this kind of they are not looking into this kind of aspects right now. I haven't seen anything like that. But in the private sector, they sometimes do that. So to the private sector, obviously, unfortunately, then there is a cost for the family for this, which can be borne by some people, but some people cannot do this. But some people also use care homes for this. When I was working in the UK, some people use care homes for this. UK didn't have a system where they could be where patients could be admitted to hospital, but there were places like either hospices or care homes which could be used for this purpose. But then again, I have to say, even in the UK, getting someone to something like this was extremely hard if it was going to be free. But if people paid, even in the UK, they were able to do this. But in the private sector, I always tell about how the carers should look after themselves because it's a big burden on them. It can be very bad on their mental health, and they can themselves end up being sick. So, if as a GP you're seeing someone who's sick, uh, and the family member who's looking after them, you may find that the family member is also having either mental health issues or physical sickness. So if you see that as a GP, encourage them to take a bit of a break at least. What I sometimes suggest is if they are with one particular child, then you can try other children to be involved, or whether they sometimes can pool a little bit of money, maybe put them in a care home. Sometimes that's called respite care. Respite care, what it does is it looks after for the patient, looks after the patient while the family can have a little bit of a break. Yes, I
Thank you very much
totally
for that
agree with what you say.
clarification, Dr. Kelum.
Any other questions?
Excuse me, sir. Sir, can a patient decide on DNR or whether it should come from the doctor's side or both?
So it's like this. A patient has the right to decide on DNA. So if so as in the UK, the law is that the patient has the ability to say no to treatment. So CPR is if CPR is considered treatment, they are able to say no. But at the same time, they are not able to demand unreasonable treatment also. So say for example, if the doctors think it's not suitable, they aren't able to demand it also. So the patient is able to say, I don't want resuscitation, that's fine. The doctor may or may not agree with it. So sometimes you may get a patient who's very well, where you think has a good chance, then the patient says, I don't want resuscitation. Then if you don't agree with it, what you have to do is you have to first think, has this patient got capacity or not? Is the patient able to look at their problems, understand it, make a decision and communicate it back to you while making a rational decision? Knowing the pros and cons, are they able to communicate it back to you? If all of these four aspects are there, then they have capacity. If they have capacity, the patient actually can make any decision which you think is irrational. Although you think it's irrational, if they have capacity, they are able to make that decision on their own. But it is good to ask a patient why they are making that decision. Say, for example, if it's due to depression, then they don't have the capacity. But if they are not depressed, if they are making it in sound mind, they can say, yes, I don't want resuscitation. The doctor doesn't have to make a decision, but if the patient hasn't, then you approach the patient or the family and then discuss with them. So what I do in my current practice is, if a very unwell patient is there in hospital, and if I don't think that they would benefit from resuscitation, because what I'm thinking is this: I may be happy to give resuscitation, but if the patient's resuscitation survival chances are almost zero, why would I put that patient through undue pain or distress? If I am in that situation, I wouldn't want it. If the chances of bringing me back are close to zero, and if I'm only going to put through pain and distress, so basically, I have been heading a lot of resuscitation teams while I was a training medical registrar in the UK also. At least more than 1,000 resuscitations I would have done on relatively younger patients. But you see the amount of pain they go through. You see the amount of rib fractures they have. Even if they come out of it, most of very, very rare do people come back to what they were. They will be like a vegetable and suffer a lot. So do you want to put them through something like that? That's what you need to think. And if it's not going to work, is it worth doing all of that and giving them all that pain? Hope I answered your question.
Yeah, sir. Thank you very much. Very clear, sir. Thank you.
Any other questions?
So I think they have a lot of questions. Yeah, but we can't finish it in one lecture, but we'll have you again sometime in the future, sir.
Sure. I saw one other question about the safest hemoglobin in someone having dementia. So there is no hard and fast rule about it. So I look at patients as a whole and decide on what the hemoglobin level should be. Generally, we take 8 as a yardstick, but for someone who has a chronic anemia, now the recommendations are you can wait even until 7. Not someone who was normally well, say for example having a HB of 11 and suddenly drops to 7, not someone like that, but someone who's been slowly trickling from about 9 to 7 over about a two-year period, then you can wait even until 7. But I would say sometimes even if people who have good quality of life, they have severely short of breath. They have had a recent surgery, like a hip fracture surgery, and the hemoglobin has dropped from about 11 to about 9. Then I may even transfuse them 1 unit of blood. So there's no hard and fast rule. I would take it from patient by patient. So hope then I think I answered some of your questions at least, and I hope you found the presentation at least a little bit useful. So at some point, maybe later in the year, we could meet up again and see whether there are any other questions and many other topics that we can discuss about.
Yes, sir. Thank you, sir. Thank you very much. And we'll call it a day. I thank Dr. Kelum Pelpola, our geriatrician at King's Hospital, Colombo, and sir has been very instrumental in being a founding member of the Council of Sri Lanka College of Palliative Medicine in 2021 as well. And he has a lot of extensive experience in the field, so we can always refer our patients and get his valuable idea. And I make this opportunity to thank my college president, Dr. Pushpa Veerasinghe, and my secretary, Dr. Sankarandani Kumara. So we'll meet again, and I wish all of you a very good night and a happy weekend. Thank you, sir.
Okay, thank you. Bye.
Thank you. Good night, sir.
Good night. Thank you.
Excuse.
Yeah, you will all
CPD
receive your
point.
certificates to the email addresses that you used to get registered.
ආයි මොන ෆෝම් එකක් fill කරන්න ඕනේ නැද්ද?
No need. Don't worry.
Okay. Thank you.
Thank you for